Welcome and thank you for joining us today. Today's webinar is titled Ethical Obligations to Ineligible Living Donors. This webinar is hosted by the AST Psychosocial and Ethics Community of Practice and is the 7th session added to their ethics webinar series. This webinar is also supported by the Living Donor Community of Practice, the Kidney Pancreas Community of Practice, and the Transplantation Society. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed on your screen. Please take a moment to answer this question while I finish the remaining announcements. This webinar is being recorded, and the recording will be available next week and posted to the Hubs and the AST webpage. Please note that your lines all have been muted so that only the presenters and panelists can be heard for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. And finally, at the conclusion of today's webinar, a short survey will appear on your screen and be sent to you via email. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to Dr. Grace Lee-Brittle.
Hi, everybody. I'm Grace Lee-Brittle. I'm a transplant surgeon at Jefferson, and I'm the coordinator for our ethics webinar series through the PSECOP. I just wanted to say thank you to our speakers, our societies, and for all of you registrants who are interested in this topic. We're so excited to share this information with you, and we're happy to see the level of excitement and engagement that we have from distributing information about this webinar. And so just want to say keep an eye out for future webinars, and we are always open to suggestions if you have other ethical issues that you would like to see transplant societies address. So thanks so much. I'm going to hand it over to Jody Jones now for introductions and yeah.
Thank you, Grace. I'm Jody Jones. I am a clinical psychologist with the Transplant Institute at University Hospitals Cleveland Medical Center, and I am a professor of psychiatry at Case Western Reserve University. I am the former chair of the PSECOP and also a past living donor myself. Carrie Thiessen, who is our current chair, and I would both like to thank Grace so much for putting this webinar together for this very important topic. So I would like to turn it over now to my co-moderator, David Thomson.
Oh, thank you very much, everyone, for logging in and attending this session. I'm David Thomson. I'm an abdominal transplant surgeon and a critical care subspecialist working at Groote Hospital in Cape Town, South Africa, at the University of Cape Town. And I'm the chair of the TTS Transplantation Ethics Committee. So without further ado, I'm going to jump into the first of our 4 speakers. That's Dr. Jen Lumsdaine. She's the lead nurse for Living Donation with NHS Blood and Transplant, a UK-wide organisation. And Jen has worked many years as a living donor transplant coordinator in Edinburgh, Scotland, so we've got an excellent accent for you. And in recent years, she's worked in collaboration with the Scottish Government to improve equity of access to living donor transplantation. So over to you, Jen. Thank you very much.
Thank you very much. And I'd like to thank Grace and the organisers for the invitation to speak today. I have no conflict of interest to disclose. So my name is Jen. I trained as a nurse in the Royal Infirmary of Edinburgh in Scotland. And here's a photo of the old Royal Infirmary. And this is where actually the first living donor transplant in the UK happened in 1960. And living donation is a very important part of UK transplantation. 1/3 of the transplants performed are from living donors, mostly kidney, but an increasing number of living donor liver transplants. And we have very comprehensive guidelines that are produced by the British Transplantation Society in association with both the Renal Association and the Liver Association. And as you can see here, the guidelines for the living donor kidney transplantation, it's embedded about the care of people who are found not suitable to donate and suggests that strategies must also be in place for appropriate emotional support and clinical follow-up for potential donors who are found to be unsuitable. And I think very importantly as well, the option of a second opinion must always be available to donors and recipients. And I think having this ethos embedded in our guidelines is extremely important, and it's mirrored in the living donor liver transplantation guidelines. Donors who are not suitable or who wish to withdraw should be appropriately supported by the transplant team. So I'm providing a really kind of background overview for the webinar today, and I thought it might be useful just to talk about the categories of potential donors. And because we all know, working in living donation, that we have many more people come forward wishing to donate than actually donate. And there's a lot of people who are immediately excluded on their past medical history. And then the next level, especially in the case of maybe a recipient has a large family or social circle, they can have multiple donors come forward, but only one donor will go ahead. And in the case of social media, there could be hundreds of people come forward. And I think in cases such as this, when only one donor will go ahead for the person doing the appeal, then if we can redirect these donors to become non-directed altruistic donors, this benefits the whole of the transplant list. So today we will be mainly talking about those who are excluded during the routine assessment or completion of their assessment. But I think it's probably really important just to acknowledge the fact that as clinicians, we might not meet everybody who is a potential donor. And the increasing evidence coming through, or speaking anecdotally to recipients, at the time of approaching end-stage organ failure, when the recipient is facing so many different treatment choices, that actually when the clinicians, when the nurses are saying to the recipient, if anybody in your family is fit and healthy and you need to discuss living donation, that's quite an emotional burden for the recipient. And sometimes the easiest choice might be just for the recipient to say, oh, well, no, I think you're too old, or I don't think you'd be a match. And also, if we're looking at the most deprived in our society who are in most need of a good living donor transplant, this study that was done in Scotland, it's part of the health survey, and it reported that only 55% of this is the general public, 55% of these people in the most deprived groups rated their health as good, compared to 81% in the most affluent area group. So already we are excluding over half the population in the most deprived areas because they will not deem their health to be good. And I think there's a lot more work we can do at a very early stage and to start assessments very early to try and overcome some of these barriers. So the donors that do approach us, and we looked at the impact of publicity, and I think these results were really interesting. This was really just a kind of workload thing to see, if we do a publicity campaign, do we get more donors coming forward? And of course we do, because anything to do with organ donation and transplantation, good publicity raises public awareness. And as you can see here in this 18-month period with a publicity campaign in the middle, we saw this spike, and over this period we had almost 1,000 health check questionnaires returned for almost 700 recipients. So probably a third of the people responding were to be non-directed altruistic donors. Colleagues in the west of Scotland looked into a cohort in more detail, and of over almost 1,000 inquiries that were received during this time, 700 assessments were discontinued, which is a very large amount. But remember, this is from the very initial inquiry. And the reasons for discontinuing, over half were perhaps an immediate past medical history, or the donor withdrew. They found out more about it. They didn't want to proceed. There might be other potential live donors going ahead, or the recipient received a transplant from the deceased donor list, or there can be recipient issues. So the actual number on the contraindications is, probably much smaller than going through the assessment. And if we look at international data, first of all, looking at the non-proceeding for kidney, and these are studies from Germany, the USA, and Korea. The 2022 studies both show over half the donors coming forward found not to be suitable to donate. And this is a huge, for the donors coming forward, and we'll hear a lot more about this in the webinar, about the emotional impact for them. but also from the workload for the living donor teams to ensure that every potential donor has the maximum chance to go forward. And interesting, I've seen that the USA study, only 20%, 24% did not proceed. So I think we need to look into that, and to see what we can learn from how to allow donors to proceed. But then when we look at the living donor liver donation, it's a much higher percentage who don't proceed. And in the early days, the study from Germany, when living donor liver was probably in its early stages, and there was a learning curve, then 86% of potential donors didn't proceed. And that's come down in the last couple of years to 61, 68% in the different countries. So I think just having this data just gives us an idea of the scale of the the people who have got expectations and hope to do something which we all support and actually don't go ahead to proceed. And just before I finish, I'd just like to just mention a couple of people who have been hugely inspirational. Jan donated a kidney. She was a non-directed altruistic donor. And she said it was fantastic. She just felt it was a privilege and it really meant something. And she was really key to founding one of the awareness charities in the UK called Give a Kidney. And she was so inspired that she went on to offer to become a living liver donor. And at the end of her assessment, she was declined. And this has really stayed with her. She knew that she'd been matched to a potential child recipient. She felt she'd let the family down, and it still stays with her. And I think it's people like Jan that we really do have such an obligation to. And the other person I think it's really important to mention is Della. And Della came forward a number of years ago, wishing to give a kidney to her brother, and she was found to be not suitable, and she was devastated. And she turned this devastation into something so positive and has made such an impact on so many people's lives. She founded the Gift of Life, which is a charity to improve active access for Black kidney patients. And she's based in London. She founded the Living Donor Choir. And she's written this book, More Than a Match, and that's about her experience of not being suitable as a living kidney donor. That's me finished. Thank you very much. I should stop sharing now.
Perfect, Jen. Thank you.
I'd like to introduce Michael Joyce, a licensed clinical social worker. Since 2009, Michael has had the distinct privilege to work with living donors for liver and kidney transplant at Yale New Haven Transplant Center. Michael also previously served as the ILDA for an extended period prior to separation of the role. Michael has contributed to publications on living organ donors, including a pilot study on reasons for and psychosocial impact of withdrawing from living kidney donor evaluation. Michael is currently engaged with the mental health work group of the living donor community of practice. He's in the process of surveying transplant centers for psychosocial follow-up of declined liver and kidney donors. Thank you for being here.
Thank you so much, Jody. I greatly appreciate this opportunity to be a part of this webinar. And I have no relevant financial related disclosures. Today, I'm going to talk about a few clinical vignettes of declined living donors, one for a medical reason and one for a psychosocial reason. Talk about how their evaluation went, and then the decision, how it was made for the decline, and then look at the literature that I found on declined living donors and look at some possible treatment, programmatic recommendations for working with this population possibly differently in the future. All right, so the first case is a kidney donor candidate a 60-year-old woman from Puerto Rico who came forward to try and donate a kidney to her older brother. Important that she self-identified as the only donor candidate in the family. The recipient was reported to have diabetes and kidney failure and was on peritoneal dialysis at home since roughly January. The initial phone screen that she did was in November of 2025. This candidate was highly educated. She performed contractual work historically and was a published author. But it was important that at the time, of her evaluation, her contract work actually ended in January of 2026. So for her, the majority of her evaluation with us, she was technically unemployed. This became important because then the financial implications for her regarding all aspects of the indirect costs of this evaluation were clearly on her mind from the onset. To that point, she was in Puerto Rico at the time. There were initially some delays in trying to get labs covered through a diagnostic laboratory that we have a contract with here at Yale. So that caused some delays. Obviously, there were going to be indirect costs of travel and lodging for her to come to Connecticut for an evaluation, and she described that very early as a concern. For that reason, I screened her eligibility, and fortunately, she was approved through the NALDAC program to cover the costs of her travel and lodging for evaluation. Her in-person evaluation eventually took place in May. There were a few months that she just wasn't available due to having prior travel plans. But I think also important to understand that during this time, she had numerous phone calls with the nurse coordinator, clearly showed a lot of engagement in wanting to donate to her brother. The initial findings from testing done again in Puerto Rico was that her blood pressure was suboptimally managed, even on one medication. When she came for her in-person evaluation, nephrology identified signs of metabolic syndrome, including hypertension, prediabetes, hyperlipidemia, and a BMI of 28. Transplant psychiatry was also involved in this evaluation because she did have one episode of major depression back in 2021. And it wasn't initially clear from the phone call, but she had a recent return of some symptoms and resumed therapy in February for reasons that were not entirely clear. When she came for an evaluation, to multiple people, including myself, when I asked her about her motivation, some of it and her thinking about donation, she mentioned feeling guilty and privileged about her own health in that discussion, which I thought was important. The donor panel met in June after her completed evaluation, and the decision was made for a medical decline. It was a multi-factor reason for this. The main was beading that was found on her renal artery. Her blood pressure was not well controlled, as already mentioned, and the signs of the metabolic syndrome. She was informed by the living donor nurse coordinator very promptly, who's a great colleague of mine. And she was noted to be very distressed, crying during the call and saying that she needed to process this. My colleague, alerted me right away. And a few days later, I called her by phone. Also important to know that all of these calls, were done with an interpreter. So English wasn't her primary language. During that call, she reported feeling down, knowing her brother was still struggling and on dialysis. She had thought about it some, and she did accept the reason for decline. Important that the nurse coordinator, notified her brother by the donor candidate's request. And I think that was really important because then he was able to be supportive of her, which she really identified as important in processing this decision. Fortunately, she also was following up with a local psychologist and family for support. I also followed up with her again on the 22nd, and again, she was more resolved in this decline by that point. The areas of vulnerability for this donor, I think, was she identified as the only living donor candidate, and she clearly had a strong bond with her brother. There was that history of depression. And the major thing was her change in life status, I think, with employment and financial implications noted. And she clearly had multiple months of investment by phone, even to get to the one-day evaluation. She did express some feelings of guilt as a potential motivation for donation decision. The second case involves a liver donor candidate. This is a psychosocial decline. 44-year-old male trying to donate to a work colleague of 10 years. He saw a video on Facebook asking for people to consider living donation. He was married with 2 children, a college grad who worked in healthcare. For this man, support for his recovery was clearly identified as a concern. His wife was ambivalent about his decision, and there was clearly strained relationships between the candidate and his family of origin. Also, his wife lost her job unexpectedly in the process, so that obviously caused some kind of financial stress on the couple, and he withdrew from consideration for several months. There also was ambivalence noted in his presentation. He was thinking about what if his child or wife or someone more proximate to him were to need this in the future. How would he feel about that? He had some mental health previous treatment. Again, a lot of this had to do with a significant family discord with his parents that had taken place over the last couple years. Unfortunately, it involved his brother's overdose. And, he had a series of visits with my colleague, Susan Rubin, a psychologist. And that was really important because it really revealed that this was a major issue that was unresolved, I think, in him. And his mother reportedly blamed him for the circumstances of his brother's overdose. He was encouraged to go back to therapy to process this more, which he did not. And eventually, you know the the thinking was that donation for this man could be an attempt to correct his self-image as never being good enough in the eyes of his mom, and also just he clearly showed those indications in how he described himself as well. So the reason was a psychosocial decline for unreasonable risk for mood and adjustment changes. In my review of the literature, obviously a decline of a living donor can be difficult with feelings of failure and disappointment potentially. Also through the literature, I think it was an important insight of one of the authors that, a directed donor can be of particular concern, in that they come maybe already having decided that they're going to be the donor, and that this evaluation process is just kind of, in other words, to just get them ready for it, maybe never having really conceived that they even could be declined. And I thought that was a really important, thing to consider between a directed donor and a non-directed donor. Recommendations, for transplant centers with this population in the future. I really think there should be clear expectations on center approval rate very early in the process, maybe at the first contact, so that donors know, hey, not everyone is actually approved to donate. And definitely communicate that decline decision if it happens clearly and timely. And I think a big thing is to ensure great communication between the living donor team, the nurse coordinator primarily, And the rest of the team, in identifying those donors that do have, a major reaction to the news, that not get pushed under the rug, and that it get referred just as my colleague did, so that it can be handled. And then obviously a transplant center has to really identify that the declined living donor is a patient population that needs more attention, and to create some sort of process or workflow, and team members involved to address that in the future. So I thank you for your time and your attention today.
Thank you very much, Michael. It's my pleasure to introduce our next speaker, Dr. Peter Reese. He's a transplant nephrologist, ethicist, and epidemiologist, and I did see his name getting cited in the previous talk. And he directs the Vanderbilt Center for Transplant Science. And over to you, Peter, just into presenter mode.
Okay. Thanks, everybody. Appreciate your patience. I don't have any relevant financial disclosures. So, I want to go at a little bit of a higher level, just about like an ethical and conceptual framework for ineligible donors. And the way that, this was taught to me at the beginning of my career was that we need to think about principles that are kind of in tension and resolve them. And one is that, we have these people who are coming forward, we just heard about them, that they feel like it's my body, I have something I want to do with it, I want to give away a kidney, get out of my way. And we have the strong duty and, emotional, moral influence in us not to harm people. And the way that we try to discharge this is through informed consent. But sometimes, we have to turn people down because we're too worried about the potential harms to them, even if people understand those. And I think what has emerged in this talk and what's emerged over the course of my career is a deeper engagement with just the idea that the non-medical benefits, the non-medical elements of donation, may be more important to patients than the risk that we're talking to them about. Okay. So I think that when we talk to donors, what we see is that what's really important to them is a sense of purpose and well-being. They are thinking about the quality of life that they experience. What's the effect of living with a sick person? They're thinking about financial stress. And we partially get our insights about the effects of donation, the effects of declining people for donation by observing what do people say who were donors in terms of their non-medical benefits, risks, experiences. And most of the data that we see, and most of what I've experienced in clinical practice, is that when you talk to people who donated a kidney, they rarely express regret. And it's not that it never happens. It does happen, but it doesn't happen very much. And we've seen this with studies by Halverson. We've seen this with studies with the big relive cohort. Of course, we have a limitation with these studies, and you'll see that with the study that I'm going to present, that response rates aren't 100%, but most of them say that donation was a positive experience. So if we accept that donation is a positive experience and that people might use terms like, I'm glad I did it, it was good that I did it, I saw some benefits, then we have to kind of contend with the other side of the coin that if we keep someone from donating, that they might experience it as being denied benefits. So this is a great study by Jim Rodriguez, and you may have seen it before, where he did a prospective study of living kidney donors at 3 centers. And what he asked them was, his staff asked these donors, what do you expect to happen and what did happen to you? And he put it into kind of 3 categories of, say, personal growth. So someone says, I feel like I've learned a lot about myself. I feel like I'm a better person for having done this. That there's interpersonal benefit, relationships were strengthened either through, I'm thinking I feel closer to the recipient, or I just feel more compassionate for people, maybe people who are sick. And then what you might think of as spiritual elevation or religious elevation, feeling that I feel like I lived up to my values, I serve as a model for others. And when Dr. Rodriguez looked at this over time prospectively, he sort of got the same global signal that most people feel good about improving someone's life. About 3/4 feel proud of themselves. They, about half reported increased appreciation for the value of one's life. But like with everything else, there were different trajectories of people's experiences, and definitely to a strong extent, the outcome for the recipient, particularly when it was a directed donation, if the recipient didn't do well, that could be very frustrating. And so, thinking about these pieces of information together, I think sometimes it's just important to kind of reframe some phrases and values that we might have picked up along the way in medical school or in ethics classes. And I definitely try to stay away from the do no harm idea. And I try to reframe it as what we're doing is we're trying to avoid unreasonable risk. And we might think of unreasonable risk as something that I decide with the patient decides with me. We collectively decide what's an unreasonable risk. And we try to also keep in mind that there are harms of action. I harm someone by giving them a drug and they have a side effect, but I also have harms of inaction. And certainly excluded donors, I think it's reasonable to think, can feel that they were harmed by watching a loved one on dialysis. And if I think about beneficence, I think about it's a restlessness that you're always looking for new ways to work with the person in front of you and find a way to help them. So, in this setting, thinking about some of these questions, I did a study with some colleagues at just one center, just a small one-center study where we looked at people who had been turned down for donation over 3 years. We did semi-structured interviews and questionnaires. And what we did is we tried to capture some domains that donors were talking to us about, but that might have been lacking from earlier studies. Quality of life, of course, but also there had been some concerns about, do donors, did they develop depression? What could that come from? So we measured depression, we measured financial security and slack, because you can imagine donating a kidney could put you under financial strain, but you could also imagine being declined could if the burdens of the recipient's illness fell in your household. And we were also interested in how they rated their providers. So all I want you to see in this slide is that we started with 276 people who had either been turned down for donation or had donated. And many people, didn't answer us. There were, 71 people, and you won't find that surprising. Some people maybe didn't want to hear anything more from the transplant center anymore, or they were just busy. But we did finish 171 interviews, of which 128 were donors and 41 were ineligible donors. What you're seeing here is I want you to focus on the two middle gray columns. We've got 43 turned down donors, and then we matched them by the category of the relationship to the recipient of actual donors. And what you can see is that overall, the outcomes were not very different. They looked pretty similar. So the depression scores, the empathy scores, the financial distress scores, the quality of life, there's not a big signal here. Most people were saying that things were okay, and most people were reporting numerically that they weren't facing bigger unexpected burdens. So we did some qualitative interviews. Well, all the donors, we said, could you please respond to me? What do you think about this statement? My life is better than it would have been if I had not donated a kidney. And to the ineligible donors, we said, here's a statement. My life is better than it would have been if I had donated a kidney. And we asked them to agree or disagree. And what we found was that in this modest size single center study with those limitations, that most of the donors basically globally felt like their life is better for having donated a kidney. And with the ineligible donors, the ones we turned down, they were more likely to say it was the same, or occasionally they would say it's a little bit worse. I don't know if this sound is going to work because I was having difficulty, but maybe you can let me know. I want to either play this for you. I want to tell you about Sue, who tried to donate a kidney and could not.
So next I'm going to read you two statements. I'd like you to tell me whether you strongly agree, neither agree nor disagree, or strongly disagree with each of them. Do you understand?
Yep.
Okay. My life is better than it would have been if I had donated a kidney to Scotty.
My life is better than it would have been if I had donated a kidney?
Yep.
I strongly disagree. I want to give him my kidney. My life will be better if I can give him a kidney.
Yeah. And again, this is a little bit repetitive, but how do you feel your life would be better if you had donated?
If I could give my husband a kidney, my life would be so much better, because I believe that we live a life that we live. And you have to look at what your core values are. I'm a nurse practitioner. I want to help people. The person that I love most in the world, I am a perfect match for.
Yeah.
And even if I were to die as a result of giving the kidney, this is so important. I would be living true to my core. You know, my life would be 100% better if I could give him my kidney.
So, you know, I think I like to play that because it's very powerful. That keeping someone from carrying out what they feel like is their life mission, the action that's very consistent with their values, can be very painful. That doesn't mean we shouldn't do it, but I think it's good to know the consequences of it by hearing it in their voice. And for the donors who said that their life is better, the common themes were they felt they felt gratitude that the recipient's health improved. And we did hear in this study as well that you know, a quarter of the people felt like, you know, I had personal growth. I did something noble. I did something extraordinary. That felt great. So, you know, in this setting, this was probably the first part of my medical career where I felt like I need to find a new way of thinking about autonomy and understanding what it means in a specific setting. And one of my pediatrics colleagues said, you need to read about relational autonomy. And I think relational autonomy is less about this idea that I'm an island and I'll control my island, and more about, you know, we are really deep into social contexts and webs. And it acknowledges the emotional aspects of decision makers and the central role of others when we make a decision. And, you know, for some of these donors, they just can't say, you know, that person's well-being is different than my well-being. You know, they might say my child's well-being and my well-being, you're not going to be able to pull those apart. And so I've definitely come for some donors, not all donors, you know, there's non-directed donors that, you know, well-being depends on self-rule, but it also depends on healthy relationships. And beneficence is a restless need or obligation to try to make life better for the person in front of you by according to their definition, through their eyes. And through informed consent, hopefully we can resolve these. We can't always. It doesn't mean that I feel like I should completely abandon my concepts of autonomy and non-maleficence, but they seem to be complicated in an interesting and positive way with this new perspective and these modified principles.
Thank you so much. Next, I'd like to introduce Carrie Thiessen, who is a good friend, as well as an excellent surgeon. She is an abdominal transplant surgeon and bioethicist at the University of Wisconsin-Madison. Welcome, Carrie.
Hi, thank you to the organizers for inviting me to speak today. And this is a very tough group to follow. But I'm going to think about ethical obligations to ineligible living donors from a slightly different perspective than the one that Dr. Reese offered. I have no conflicts of interest to disclose. I do have some research funding as listed there, none of which is directly related to the topic today. So I've actually been thinking about obligations to individuals who declined as donors for many years now, ever since I helped to run a study on a cohort of individuals who presented for living kidney donation across 3 centers. And we were asking them what their attitudes were toward risk assumption for potential donors. And we had in that cohort a group of people who had declined as donors who shared many sentiments similar to that expressed by the patient that Dr. Reese presented that audio clip on. And in my prior life, before I decided to do transplant surgery, I actually thought that I was going to do work in international clinical trials and the ethics of that. And in that work, I came across this idea of the partial entrustment model. And this model was first developed by Henry Richardson and Leah Belsky in 2004. They published 2 articles on it, and then subsequently Henry Richardson went on to write this book called Moral Entanglements, in which he further elaborated this theory. And it was designed to assess the obligations of medical researchers to provide ancillary care to clinical trial participants, many of those individuals participating in clinical trials in low-income countries. And ancillary care, they defined as care beyond what was required for the safety and scientific validity of the study. And so you may ask, well, okay, this is about clinical research. Why does this come to mind when thinking about potential living donors? So I'm going to argue that living donors are very similar to research participants in many respects. Living donors, like many research participants, though not all the research participants, are healthy volunteers. They come forward with the possibility of accepting harm for the benefit of others. They provide voluntary informed consent to engage in the evaluation, the clinical trial, potential donation. And there's a very analogous relationship that living donors have to the clinical trial, to their transplant team, as research participants have to their clinical trial team, which I'll talk about in more detail. So I'm going to argue that this model of partial entrustment that Belsky and Richardson elaborated is a very useful tool for us to think about our obligations to individuals who are declined as donors. So this model that they developed posits that there's a special moral relationship that exists between, and here I'm going to switch what they were referring to for the clinical trial participants and the researchers. I'm just going to switch now into the mode of thinking about as donors and transplant teams. So there's a special moral relationship between the potential donor and their transplant team that gives rise to special obligations. This moral relationship and obligations are the unintended byproduct of voluntary transactions that are undertaken for other purposes. And this is a quote from their book, but simply providing transplant teams with special permissions, potential donors effectively entrust the transplant team with special responsibilities to look after needs they discover by acting on those permissions. By the same token, by accepting the potential donors' needed permissions, the transplant team becomes effectively entrusted with such special responsibilities. Okay, so what does this mean? So partial entrustment, it doesn't exclude the existence of other moral duties that might exist for the transplant team. So there's still the rule of rescue if someone shows up for their evaluation appointment and they're having acute angina, that doesn't really necessarily fall under partial entrustment obligations. That may fall just under a straight up rule of rescue. You send the person to the emergency room and ensure they get appropriate emergency care. It's not saying that there are no other potential grounds for special obligations to individuals who are ineligible. If you've promised to do something, then that's a separate reason for fulfilling that promise. And of note, despite all of those appeals that you heard to the psychological reality that the potential donors have of feeling that maybe their transplant team has a special responsibility for them, and the sense that we may have as providers that we have special responsibility for ineligible donors. Richardson and Belsky actually say that their partial entrustment model does not rely on the psychological experience of either party involved, that this is something that just arises explicitly because of the nature of the procedures that are involved as part of the protocol that needs to be followed. Okay, so they offer a description of partial entrustment obligations that rely on both scope and strength. So scope of partial entrustment, it's specifically related to the procedures that are required by the protocol. And partial entrustment, they argue, only applies when something is identified as a result of special permissions that were obtained by that protocol that you needed those special permissions to discover. So they give an explicit example. If someone has a deformed limb, that's something that anyone could see. You didn't require any special permissions or any special tests to determine that that was a problem. Therefore, you're not responsible for dealing with that. And that maybe is not perfectly analogous to the living donor situation, but I just put this image here of like a donor CT scan because, as we all know, there are lots of incidentalomas that are discovered on CT scans. Those CT scans are explicitly part of the key procedure that's required by protocol to be evaluated as a living donor. And those incidentalomas are things that people had no clue that may have existed prior to the CT scan. So that would be something that clearly falls within the scope of this model. Richardson and Belsky also offer 5 criteria to assess the strength of the partial entrustment obligation. So they say vulnerability, which they define as how much of a difference would getting the care in question make to the health or welfare, in this case, of the donor candidate. The depth of the relationship, so how expectably intense and long-lived was the relationship. Again, that's the expectably intense, not the actual psychological experienced intensity. The degree of gratitude. So is the potential donor owed any special debt of gratitude for his or her willingness to have undergone procedures that are risky, painful, and or inconvenient? The degree of dependence. So how dependent is the donor candidate on the transplant team for getting that care? And then in there, this is from their original article. In the book, they subsequently changed that importance of reasons against to cost. And they described it as the cost in terms of budget, personnel time, and ability to gather the relevant information to providing the care. Okay, so I think this framework offers us a useful way to think about the bounds of our obligations to provide care for individuals who are ruled out as potential donors. So this is, that famous map, primarily designed for individuals who are candidates going through the transplant system, but there is this component that includes living donor evaluation. And so here on this map, someone you can imagine before their in-person evaluation appointment at point T. So this is maybe someone who has expressed an interest, was given the link to the pre-screening questionnaire online. They filled out the pre-screening questionnaire online, and it comes back to them saying, due to some of the information you provide about your past medical history on this survey, you are not eligible to be a candidate as a potential donor. So just thinking about this, right, there hasn't been an extended point of contact between that individual, the transplant team. There is not clearly high vulnerability. They haven't undergone a lot of inconvenience or pain or discomfort at that point. And so I would posit that this is a low obligation situation, and those obligations might be fulfilled by simply putting as part of that notification online how to contact someone in the transplant team if that individual has further questions about why they're ineligible. So in contrast, you can imagine someone who comes in, like maybe in that first case that Michael Joyce was talking about, someone who comes in, they've spent a lot of time communicating with the transplant team. They've undergone a lot of the workup for their in-person evaluation, and there's a medical condition that was identified. And so in the interest of time, I won't go through all of this, but I'll just say that I think this is a higher obligation situation. And there are specific obligations that may be generated. And sort of minimally, that would be kind of sharing the relevant newly diagnosed medical condition information with their primary care provider, ensuring referral to appropriate follow-up care, and then the kind of follow-up contact with the transplant team that Michael and his team provided. In a case where someone likewise comes in for in-person evaluation and they're declined, but not for medical reasons, but for financial concerns, one might argue, again, I won't go through all of this in the interest of time, but you might argue that this actually falls outside the scope of the duties that are required for the transplant team, according to this theory of partial entrustment. And therefore, they fall under sort of general moral duties to help people in financial need, but that this maybe doesn't engender a whole range of required follow-up on behalf of the transplant team. So I'm just going to suggest that this idea of partial entrustment, I've talked about primarily in relationship to individuals who are ineligible to donate, but I think we could use it to think about our obligations also to donors and those who opt out of donation, and that there may be different factors that come into play for those groups in terms of the strength of those obligations. But we need to think a little bit more about how this model helps us or doesn't help us specify the duration of the obligation that the transplant centers are required to fulfill. So this partial entrustment model, I think it suggests that we have obligations to ineligible donors. It offers a framework for helping us determine what the strength of those obligations are, and it helps us think about limiting the scope of those obligations. And I'll just end there by saying that I think transplant centers should revise their clinical practice to fulfill the obligations specified by this model. Thank you.
Thank you to all of our speakers. You guys did just a wonderful job. We did have one question come through the Q&A, and if anybody else wants to post something, we can definitely address more. There's the one question, and then I had actually written down something someone had put in the chat. So the first one is from actually a wonderful social worker who works with me here at UH, but she said, to what extent does the transplant team involve themselves with referring distressed or declined living donors to follow-up services like psych, if appropriate?
Can I answer that?
Mm-hmm.
Yeah. I mean, I think that is absolutely optimal care for any potential donor who has stress and would benefit from further input. I think that probably many transplant centres have limited resources when it comes to psychological support, but that would definitely be the optimum. And also, if there's any community follow-up and community psychiatric care. But yeah, I mean, it's alongside the medical, the psychological support is key.
Thank you, Jen. And I will say from my own observation, I used to do all of the psychosocial evaluations at a previous transplant center. And I always felt like the coordinator was very, very sensitive to what was going on with the potential donor. And for those that were getting turned down, she was often coming to me and say, can you have a follow-up session, or can we figure out a way to get them something locally? So I do think that coordinators do an amazing job of kind of, keeping their ear to the ground for things like that. There was another question that I had written down in the chat, and I see another chat message question has just come up. It was actually during Jen's talk, and someone had made an observation about timing sometimes being a barrier for donors and for people who get turned down, like kind of observing what percentage of people might come back at a different time. And I don't know if any of you guys have thoughts or have actually interviewed people that came back for a second round when it seemed like there was maybe a reason, metabolic condition or something like that kind of temporarily ruled them out, and then seen them come back. Just thoughts on that?
Yeah, I can speak to that. That's definitely happened at our center, and I think it was really important, say at the first time that they come in, that it's very clear, kind of what are the parameters that they're going to need to meet, in order to come back. And I can think of a few examples, like you said, alluded to, Jody, metabolic sort of issues or weight loss or, things like that. And I think it was really important to give them, just a very clear, indication of what that is, and and then referring them back to their primary care, to work on those things before they came back. So I think it's important that was important in those examples.
I also think I was just going to say that, I think sort of implicit in a lot of this discussion is that the goal ideally is to hand a donor back to, a social network or a care network, a primary care doctor, a therapist that's in their community and can have an enduring relationship with them. I think one of the difficulties with the transplant centers, it's not designed and engineered to provide ongoing support. But that ideal can be very difficult, at least in the United States, where there's such a crisis with a lack of primary care doctors. So sometimes I think we also wind it up in the situation of, hoping that we can connect someone with primary care.
We've got some more questions that are coming up in the chat, and there's a little bit of a theme here. So if I can, I'll try to sort of condense the idea. But the notion that people sometimes need an alibi to get out of donation, and also addressing sort of the messaging, because I think it is very true that across transplant centers, some place will totally give a medical excuse for someone who needs the personal out, and others, have different sorts of messaging or whatever. So, the question being, what are your thoughts on that? I guess the ethical providing of an alibi for someone, and whether that should be sort of a consistent thing done across transplant centers.
Well, maybe I could take a stab at that. So I think, the process of opting out, there are a lot of overlaps with individuals who are ineligible. But I think one of the key tenets for both is that we, as transplant centers, ideally do not want to make people worse off in their relationships than they were when they began their evaluation process. And the option of an alibi, I think, I've written about. It's something that many transplant centers do offer, even explicitly in their initial evaluation consent form. But I think there are strong reasons for not offering a specific medical reason, but having a general statement of medical ineligibility or of ineligibility that is offered to the intended recipient. And, that's neither a lie, right? Because if you opt out and you don't want to donate, you're not eligible to be a donor. Nor does it run into some of the problems that happened in the past when specific medical reasons were attached, sometimes even to individuals' their charts and medical records, when those things may have not been completely accurate and cause problems in the future. And sometimes the reasons that people opt out change over time. And then if those things are permanently in their record, then it's very difficult for them to potentially donate again in the future.
Brian, do we have to cut this off right now? I know it's technically the end. I don't know if there are people who want to hang around and speak just a little bit longer and address a few more questions.
Hi, Jody.
Hi, Doctor.
Sorry, Brian.
No, go ahead, Raf.
No, go ahead. I was going to say if there is one more question that you would like to address, and then we can wrap up.
David, did you want to ask one of yours?
So maybe I'll just close. I mean, I think we put the donor front and central here. I think one of the things we struggle with in a resource limited setting is that we don't have independent donor advocates. And when it becomes a high pressure situation like living liver donation, maybe parents to a child, that is a highly stressful, emotional, and time pressured situation. How do you manage to do this appropriately in that setting? I don't know, maybe probably best to direct that to Michael or to Jen, who are doing it on the coal face.
I mean, I think you do. I think you do the best you can. Fulminant liver failure is a very special situation, right? Where, evaluation has to be done, much quicker than on an outpatient typical basis. I don't know. I mean, if you don't have a donor advocate, can it just be another, can it be another person in transplant who can come in and serve that role? Can there be, I think you just do the best you can, you know. It's a tough one, David, because you have those time constraints.
It probably feeds back to Peter's point that you're putting them back into a network afterwards, that it's not a single point in time as well. But yeah, it is a challenge, and it's almost a role that you have to carve out discreetly. It really has to be a truly respected role in the process. Yeah.
And just so I could add to that, I think there's quite a lot of power in the multidisciplinary team meetings as well. So it's not just one, it's not, the decision is not just lying with one person, it's a collective decision. And also, I think the option of a second opinion is truly helpful. I know everybody's resources are so limited, but I think, just for the donor and for the recipient, having that option, and for the clinical team, I think that's really valuable.
Cool. Well, thank you very much, everyone. It's been a really successful webinar. I know I've learned a lot, and I have some reading to go and do. And thank you for AST to putting it together and our speakers. Really appreciate your time, and I think we had excellent attendance and great engagement. So thank you to everyone involved. And then I think it's Rafaela who has to do the final wrap up.
Thank you. Just want to take a moment to thank all of our panelists and all of our attendees for today's session. Please remember to complete the evaluation survey that will be sent to you shortly, and the recording of the session will be made available next week and posted. Thank you again.